Welcome to OET Answers.
Occupational English Test. OET Answers Practice Test, Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. You hear a nephrologist talking to a patient called Anita. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hi, come on in, Anita. You've been referred to me because of some concerns about your kidney function, specifically related to IgA nephropathy. Is that right?
Yes, that's what my doctor said. To be honest, I'm still not entirely sure what that means. I've been reading a bit about it online, but it's a lot to take in.
I completely understand. IgA nephropathy can sound a bit overwhelming, but I'm here to help explain it and guide you through what it means for your health. Let's start by talking about how you've been feeling and any symptoms you've been experiencing. How long have you noticed something was off?
Well, I've been feeling tired a lot, but I just thought it was stress or lack of sleep. Then, a few months ago, I started noticing blood in my urine. It wasn't all the time, just off and on. That's when I went to my GP, and they ran some tests. That's how I ended up here.
Blood in the urine, or hematuria, is one of the key signs of IgA nephropathy. It's good that you saw your GP when you noticed it. Did you have any other symptoms, swelling in your legs, changes in how often you urinate, or any pain?
Not really. I mean, maybe I've been going to the bathroom a bit more often, but I just thought that was normal. No pain, though, and I haven't noticed any swelling.
That's helpful information. IgA nephropathy, also known as Buerger's disease, is a condition where a protein called immunoglobulin, IgA, builds up in the kidneys and causes inflammation. Over time, this can affect how well your kidneys filter waste and fluid from your blood, which is why you might notice blood in your urine or changes in your bathroom habits.
So, it's an immune problem? Like my body's attacking my kidneys?
In a way, yes. Your immune system is depositing IgA in the tiny filters of your kidneys called glomeruli. These filters are supposed to remove waste and excess fluid from your blood, but the buildup of IgA triggers inflammation. Over time, this inflammation can cause scarring, which can affect kidney function. But it's a slow process, and in many cases, people live with IgA nephropathy for years without major issues.
That makes sense. But I'm worried. Does this mean I'll eventually need dialysis or a kidney transplant?
It's understandable to feel concerned, but not everyone with IgA nephropathy ends up needing dialysis or a transplant. In fact, many people manage the condition with medication and lifestyle changes and don't experience severe kidney damage. However, some people do develop chronic kidney disease over time, which is why it's important to monitor your kidney function regularly and take steps to protect your kidneys.
So, what's the plan? What can I do to make sure it doesn't get worse?
The good news is that there are several things we can do to slow the progression of IgA nephropathy and protect your kidneys. One of the most important things is controlling your blood pressure. High blood pressure puts extra strain on your kidneys, so we'll need to keep that in check. Your GP may have already started you on medication for that. Are you currently taking any blood pressure medications?
Yes, my doctor put me on something called an ACE inhibitor a few weeks ago. I think it's called lisinopril.
That's excellent. ACE inhibitors like lisinopril are often the first line of defense for people with IgA nephropathy. They help lower blood pressure and also reduce protein loss in the urine, which can help protect your kidneys from further damage. Have you had any side effects from the medication?
Not really. I've been feeling okay, maybe a little lightheaded at first, but that went away after a few days.
That's good to hear. It sounds like the medication is working well for you, in addition to keeping your blood pressure under control. We'll also monitor your kidney function with regular blood tests to check for signs of declining function or increased protein in your urine. Have you had a urine test recently?
Yes, my GP did one right before I came to see you. They mentioned there was some protein in my urine, but they didn't say how much.
A small amount of protein in the urine is common with IgA nephropathy, and we'll keep an eye on that over time. If the amount of protein increases, it could be a sign that the condition is progressing, but with the right treatment, we can often keep protein levels stable or even reduce them.
That's a relief. I was worried it was going to get worse quickly.
It's a slow process for most people, and the key is catching it early, which we've done in your case. In addition to medication, we'll talk about some lifestyle changes that can help support your kidney health. For example, reducing salt intake can help control your blood pressure and reduce the workload on your kidneys. Have you been making any dietary changes since your diagnosis?
I've been trying to eat healthier, cutting out processed foods, but I haven't really focused on salt specifically. Should I be doing that?
Yes, reducing salt is one of the most important changes you can make. High salt intake raises blood pressure, which can damage your kidneys over time. We recommend sticking to no more than 2,300 milligrams of sodium per day, and ideally, even less if you can manage it. Avoiding processed and packaged foods is a great start, as those tend to have a lot of hidden salt.
I'll definitely start paying more attention to that. Is there anything else I should be doing?
Extract 2, questions 13 to 24. You hear a fertility specialist talking to a patient called Emma Jameson. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Good morning, Mrs. Jameson. I understand you're here to discuss some concerns about your ability to conceive. Could you tell me, in your own words, what's been going on?
Yes, it's been quite frustrating to be honest. My husband and I have been trying for a baby for about 2 years now, and nothing's happened. At first, we thought we just needed more time, but now I'm starting to worry there might be something wrong.
I see. I understand that can be very stressful. Have you been tracking your cycles or using any ovulation tests during this time?
Yes, I've been using ovulation kits for about a year. I usually get a positive result each month, so I know I'm ovulating. But still, nothing seems to be happening. My periods are pretty regular too, usually around 28 days, and I don't really have any pain or abnormal symptoms with them. But despite all that, it's just not working.
Thank you for that information, it's helpful. And in terms of your general health, have you noticed any changes over the past few years? Things like weight gain, changes in your skin or hair, or any other symptoms?
I did put on a bit of weight a few years ago, about 10 kilos. I've been trying to lose it, but it's tough. Other than that, I feel fine really. No major changes that I can think of. I do have some issues with my skin sometimes, like breakouts, but that's been happening for years.
That's good to know. And in terms of medical history, have you been diagnosed with any conditions that could affect fertility, like polycystic ovary syndrome, PCOS, or endometriosis?
I haven't been diagnosed with anything like that. I've heard of PCOS, but my GP didn't think it was likely because my periods are so regular. And I've never had surgery or anything related to endometriosis.
That's fair. Regular periods do make conditions like PCOS less likely, but it's still worth exploring further. Now, I also noticed in your notes that you're years old. Age can be a factor, as fertility tends to decline gradually after the mid-S.
Yes, I've read about that. I didn't think about my age much when we started trying. But now that we've been trying for a while, it's hard not to worry that maybe I've left it too late.
It's understandable to feel that way, but the good news is that we have a lot of options to help you, regardless of age. Now, let's talk about your husband's health for a moment. Has he had any tests or faced any issues that could impact fertility?
He's healthy as far as we know. He's 38, and we did some basic testing at the GP's office. His sperm count came back normal, and he doesn't have any known issues. He's been really supportive, but I know this whole process is stressful for both of us.
I'm glad to hear he's been tested already. That's an important part of the process. Infertility is often a combination of factors from both partners, so it's always a good idea to rule out as much as we can early on. Now, in terms of your next steps, I'd like to suggest a few tests.
Okay. What kind of tests?
The first thing we'd look at is something called an antral follicle count, which involves an ultrasound to check how many egg follicles are present in your ovaries. This gives us an idea of your ovarian reserve, basically how many eggs you still have. We can also do a blood test to measure your hormone levels, particularly anti-Müllerian hormone, AMH, which also helps assess ovarian reserve.
That sounds fine. Is there anything else we should be looking at?
Depending on the results of those tests, we might also want to do a hysterosalpingogram, an X-ray of your uterus and fallopian tubes. This helps us see if there are any blockages or abnormalities that could be preventing sperm from reaching the egg or stopping the egg from implanting properly.
Okay, I've heard of that one. It sounds a bit uncomfortable, but I'm ready to do whatever it takes at this point.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear a doctor and a nurse reviewing a patient undergoing a general examination. Now read the question.
All right, this patient has been on a ventilator for a while. We've managed his vital signs fairly well so far. His blood pressure is stable and his heart rate is within acceptable limits. However, there's still no sign of spontaneous breathing. Do we see any signs of trauma?
There's a slight bruise on the scalp, but no major external signs of head injury.
Okay, noted. Have you checked for any evidence of drug ingestion?
Yes, there are no track marks, and we've accounted for all the sedation administered.
Good. Let's check his pupils again. How are they?
They're still dilated.
Dilated pupils, but stable vital signs and no major trauma or drug use. He's not showing signs of spontaneous breathing, though. This suggests that we might be looking at prolonged ventilator support at best.
Now look at question 26. You hear a nurse taking to a doctor about a patient. Now read the question.
Six-year-old woman who came in this morning with a rather unusual concern. She noticed that her eyebrows have completely disappeared over the last few weeks. At first she thought it was stress, but when both eyebrows vanished entirely, she became worried. She's otherwise healthy, no fever or other complaints, and her scalp hair remains intact.
That's quite interesting. Based on the symptoms, I suspect we could be dealing with an autoimmune condition like alopecia universalis, which causes complete hair loss from the entire body, including the eyebrows. Though less common, it can be associated with disorders like thyroid dysfunction or other immune system issues.
She does seem quite anxious about her appearance, but she's in good spirits overall. What would you recommend as the next step?
First, we should order a comprehensive blood panel, including thyroid function tests and autoantibody screening, to evaluate any underlying conditions. We also need to refer her to a dermatologist for confirmation of the diagnosis. Early identification and treatment could help manage the condition.
Now look at question 27. You hear an instructor talking about myopia management. Now read the question.
Hello everyone, and welcome to today's program. The objective is to provide a case-based, interactive clinical refresher program in myopia management for practicing optometrists. This program is not suitable for those focusing on subspecialties outside of myopia management, as we will focus on routine and evidence-based strategies to slow down the progression of myopia in patients. The program will cover topics like orthokeratology, ortho-K, multifocal contact lenses, and atropine therapy. Through case studies and practical workshops, we'll explore how these strategies are applied in everyday practice. We will end with a panel discussion on future developments in myopia management and the challenges of integrating these into routine care.
Now look at question 28. You hear a conversation between two medical professionals. Now read the question.
Good morning, team. Today we will review the latest developments regarding healthcare cost management strategies. Tom, could you get us started, please?
Certainly. As we discussed last week, one of the key contributors to rising healthcare costs is the increasing price of medical procedures and prescription drugs. The new proposal from the board focuses on regulating hospital charges and promoting generic drugs. Early estimates suggest that the implementation of these measures could reduce overall costs by about 10%. The detailed financial breakdown will be available next month.
Okay, while we await the final numbers, we'll continue to monitor spending closely and work on increasing patient awareness regarding the availability of cost-effective treatment options, particularly generic medications. Next, we have
Now look at question 29. You hear a medical professional explaining a zoonotic transmission. Now read the question.
Last week, a case of zoonotic transmission was identified in a domestic animal that tested positive for COVID-19 after its owner had been diagnosed. This highlights the ongoing risk of zoonotic diseases during pandemics. Zoonoses, such as COVID-19, can pass from animals to humans, and veterinarians play a crucial role in both monitoring and preventing these types of transmissions. Although there is no solid evidence of significant transmission from pets to humans, there have been isolated cases of animals contracting the virus. As the pandemic progresses, veterinarians are working with public health officials to study the virus's effects on animal populations, particularly in livestock and wildlife. Additionally, they are monitoring potential mutations of the virus in animals, which could impact human health. Now, veterinarians are conducting detailed screenings of animals that have been in close contact with COVID-19 positive individuals to further understand the transmission dynamics. This will help confirm whether any genetic changes in the virus could pose new risks for humans and the potential future emergence of other zoonotic diseases.
Now, look at question 30. You hear a nurse talking to a patient called Miss Taylor. Now read the question.
For emergency care due to chest pain. I want to reassure you that we're working as quickly as possible, but there are quite a few critical cases ahead of you right now. In the meantime, let me go over a few important safety measures while you're here. It's crucial to know about our triage process, which ensures the most critical patients are treated first. And to stay informed about how overcrowding can impact wait times and care delivery.
I understand. It's busy in here. I was wondering how much longer I might have to wait.
It's hard to predict exact wait times, but rest assured, we will attend to you as soon as possible. In the meantime, here's a safety guide that goes over a few things: how we prioritize patients based on severity, how to stay safe during your wait, and steps we take to manage overcrowding. I recommend you keep it with you and share it with any family members who might join you here. Feel free to ask me any questions when I come back to check on you.
Thank you. This helps me understand the process better while I wait.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For question 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Extract 1. Questions 31 to 36. You hear a speech pathologist, Dr. Rachel Summers, giving a presentation to a group of trainees. You now have 90 seconds to read questions.
Good afternoon, everyone. I'm delighted to have the opportunity to talk about a very important topic today, especially for those of you interested in working with children or in child psychology. We're going to explore how language development differs in children diagnosed with autism spectrum disorder, ASD. This knowledge is essential for those working in pediatrics, as it will allow you to assist parents and make timely referrals to specialists. Autism spectrum disorder is a complex developmental condition that impacts communication and behavior. A core feature of ASD is difficulty with social interaction and communication, and these challenges often manifest in language development. However, the degree to which language is affected can vary significantly from one child to another, as ASD exists on a spectrum. Children with ASD can experience delays in language acquisition or show unusual patterns in language use. For instance, some children may not speak at all, while others may develop fluent speech but struggle with pragmatic language, which refers to the social use of communication. Pragmatic difficulties may include challenges understanding nonverbal cues, adjusting language to suit the social context, or participating in the give and take of conversations. Even when these children develop a good vocabulary and grammar, they may still have difficulties using language in social settings. Echolalia is another common feature observed in children with ASD. This refers to the repetition of words or phrases they've heard, sometimes immediately or after a delay. While it might appear as a sign of language competence, it often reflects difficulty generating spontaneous speech. In fact, many children with ASD rely on echolalia as a strategy to cope with communication demands they find overwhelming. The prevalence of language challenges in children with ASD is significant, with about 1/4 of these children not developing functional verbal communication. However, early intervention can make a huge difference. With timely and effective therapies, many children show improvements in their ability to communicate, especially in the area of social communication. A key intervention for these children is speech-language therapy, which aims to develop both verbal and nonverbal communication skills. The development of language in children with ASD can also be influenced by co-occurring conditions. For example, some children may have intellectual disabilities, which further complicates language acquisition. Others may have attention deficit hyperactivity disorder, ADHD, which can interfere with their ability to focus during communication or therapy sessions. For these reasons, it's crucial that professionals involved in the care of children with ASD take a comprehensive, multidisciplinary approach. Early signs of communication difficulties may become apparent in infancy. These include limited babbling, a lack of gestures, and poor eye contact. Parents and caregivers should be encouraged to seek professional evaluation if these signs are noticed, as early diagnosis and treatment can significantly improve long-term outcomes. Another important aspect of language intervention in children with ASD is the role of augmentative and alternative communication (AAC) systems. These systems can be invaluable for children who have minimal verbal communication skills. AAC can include anything from picture-based communication boards to speech-generating devices. For many children, AAC systems provide a pathway to functional communication that would otherwise be difficult to achieve. Families play a critical role in the success of language interventions for children with ASD. It is essential for therapists and other healthcare professionals to work closely with the family to ensure that therapy goals are reinforced at home and in other social settings. By doing so, children can practice social skills in a variety of contexts, which greatly enhances their progress. This collaborative approach, involving speech therapists, occupational therapists, psychologists, and educators, tends to produce the best results. Lastly, it's important to remember that children with ASD have highly individualized needs, and no two cases are the same. For some children, therapy may need to focus on enhancing verbal language, while for others, it might be more about developing social communication skills or using alternative communication systems. In all cases, a tailored intervention plan is key to ensuring that each child reaches their full communicative potential.
Extract 2. Questions 37 to 42. You hear a conversation between a journalist and Dr. Abbott discussing organ donation regulations. Now, read the questions. You now have 90 seconds to read questions.
Today, we're discussing a critical issue in healthcare, organ donation regulations. Joining us is Dr. James Abbott, an expert in transplant ethics. Dr. Abbott, why is the process of organ donation still such a highly regulated and debated topic in healthcare?
You're absolutely right. It's an important topic that's been the subject of heated debate for many years. The central issue lies in balancing the increasing need for organs to save lives while ensuring ethical practices remain intact. On one hand, there are thousands of patients waiting for transplants, many of whom die due to the lack of available organs. On the other hand, we need to ensure that donations are made with proper consent and that organs are distributed in a way that is fair and transparent. It's a difficult balance between supply and ethical considerations, and finding that balance is a significant challenge.
What regulations are currently in place to govern organ donation?
The laws vary by country, but most nations have regulations designed to ensure organ donation is voluntary, and that the donors, whether deceased or living, or their families, have given informed consent. In addition, there are strict guidelines about who can receive an organ. It's not only about medical compatibility but also about ethical and social considerations. For instance, some regions prioritize younger recipients or patients who haven't engaged in risky behaviors such as substance abuse. In the US, the United Network for Organ Sharing UNOS manages organ allocation to ensure the process is equitable, but as you might imagine, there are still debates surrounding this.
Can you tell us more about the controversies that arise from these regulations?
One of the biggest sources of controversy is the debate between presumed consent and explicit consent. In some countries like Spain, presumed consent means that unless a person has opted out, they are considered a donor upon death. This system has led to higher organ donation rates, but it raises ethical concerns about whether people are truly informed or whether it's right to assume consent. Meanwhile, in countries like the US where explicit consent is required, the donation rates are lower because many people don't register as donors, even if they're in favor of organ donation. This ongoing debate sparks the question of whether presumed consent might be a more effective system, but it's a tough issue for any country to tackle.
Are there risks associated with presumed consent?
Definitely. The main risk is that families may feel their loved one's autonomy was not respected, especially if they were unaware of the presumed consent law. This can lead to public mistrust in the healthcare system. Maintaining trust is crucial for the success of any organ donation program. If people start to feel that their autonomy or their loved one's wishes are being ignored, they may oppose organ donation altogether, even in cases where lives could be saved.
How do living donors fit into this scenario?
Living donors are a vital part of the organ donation system, particularly for kidneys and parts of the liver, which can be donated by a living individual. However, the regulations surrounding living donors are even more stringent. This is to ensure there's no coercion and the donors fully understand the risks involved. There's also a significant ethical dilemma about whether people should be allowed to sell their organs. Some argue that a regulated market could alleviate the organ shortage, but most ethicists oppose this idea due to the potential for exploitation of vulnerable individuals.
How are organs allocated once a donor is found?
It's a complex process. Once an organ becomes available, there are several criteria used to determine who receives it. Medical urgency, compatibility between donor and recipient, and the time spent on the waiting list are all taken into account. Geographical proximity can also influence allocation, as the timing of transplantation is critical. However, this system has its challenges. Some patients feel they've been unfairly bypassed for an organ, leading to legal disputes or calls for changes in policy.
Are there any innovations or new trends in organ donation that we should know about?
One promising trend is the use of advanced technology to improve the matching process between donors and recipients. For example, some hospitals are using machine learning algorithms to predict the success of a transplant, which could reduce rejection rates. Another fascinating development is xenotransplantation, where organs from animals are used in humans, though this is still in its infancy. Both of these trends offer exciting possibilities, but they also raise new ethical questions. For instance, Could artificial intelligence introduce bias in organ allocation? And what about the ethics of using animal organs in humans?
Organ donation certainly seems to be a topic that will continue to evolve over time.
Yes, it's a field that's always changing, but I'm optimistic. Although there are significant challenges, both ethical and logistical, we're also seeing tremendous innovations. The key is to integrate these advancements while upholding the ethical standards that protect donors and recipients alike. Public education is also critical. When people fully understand the donation process and feel confident in how organs are allocated, we can improve both donation rates and patient outcomes.
Thank you, Dr. Abbott, for sharing your expertise on this vital subject.
That is the end of Part C. You now have 2 minutes to check your answers.